Good morning. My name's Phil Booth. I'm an ER nurse with 40 years of experience. In my 40 years as an ER nurse, I have seen just about anything and everything: traumas, amputations, strokes, heart attacks. But the most frustrating thing that I've run across in those 40 years is the ability to get an IV or not get an IV. When patients come in and we can't get a line, it takes a lot of resources, it takes a lot of time. And ultimately, sometimes we actually end up putting a central line in a patient that doesn't need it. So I'm going to talk about how to get a good line using ultrasound with regular peripheral IV. These are our objectives. We're going to talk about the physics of ultrasound. We're going to talk about how you can actually see what you want to see looking into the monitor on the ultrasound machine. And we're also going to talk about practicing in a phantom arm. Which is the way you're going to be able to, you practice in a phantom arm, and then when you get to the actual patient, it's pretty easy. It's pretty much the same thing. So let's start with the history of starting IVs. When I got out of nursing school, I learned to start IVs. You know, we see a vein, we palpate the vein, we insert the IV. But sometimes we didn't see the vein, but we could palpate the vein. So we could still, pretty easy to start an IV. But then there were patients where you couldn't see the vein and you couldn't palpate the vein. You saw something that kind of looked like a vein, so you went ahead and went after it. And that's a blind stick, and most of the time you didn't get anything. Sometimes you might even put a needle in a tendon or a nerve. And then I learned to put a 24 gauge catheter in a thumb vein and drip the blood into a micro tube and feel like I was doing a pretty good job. And there was a time when nurses in our facility could do EJs, but we can't anymore. But doctors can, but who really wants an external jugular vein? Who wants an IV in their neck? Not me. And then we also can do foot vein cannulation, but those are usually small veins. They're not as easy to hit as they look like. And it's a long way from the central circulation. Some hospitals have trained their nurses to do interosseous, but you can't leave an interosseous in for more than 12 to 24 hours. And then there's the convenience IV, where you get the doctor to put in an IJ or a subclavian, a central line, just because you can't get a peripheral IV. And that's just wrong. So at our facility, we use a thing called SBAR, Situation Background Assessment and Recommendation. The situation was we had a lot of patients. We had patients like a lot of sicklers, dialysis patients, obese patients, post-chemotherapy patients that had terrible peripheral veins. The background was we'd have to get the doctor to do an EJ or an IJ. The assessment was nurses, we do IVs. We're skilled in peripheral IVs. What we need is a tool. And ultrasound is that tool. And then the recommendation, well, we were very fortunate at our facility. We had 3 physician experts in ultrasound. So they worked with the nursing staff in putting together a program where we could learn how to stick ultrasound and be proctored. So we did it right and got good at it. Fortunately, for those of you who work in hospitals where the administrators are afraid of anything, there's a lot of evidence-based practice out there now. So if evidence-based practice is your thing, there's plenty of it. It's easy to sell ultrasound peripheral IVs because the evidence shows it's really awesome. We actually did a study where we had a poster several years ago where basically we saved almost 30 minutes per patient in difficult sticks by using ultrasound. And if you were sick, if you needed blood, if you needed antibiotics, what would you rather have? Would you rather have an 18 gauge or a 24 gauge catheter? The 18 gauge with ultrasound is easy to put in. The 24 gauge without ultrasound takes 20 minutes just to find a little thumb vein to put it in. So it's not even close to what we can do with ultrasound. Why use ultrasound? Well, it's safe. The truth is, I started this because for me, I wanted to get the line in. I call it the 3 Gs. Get the line in, get the blood out, and then get on to the next patient. And for me, it was like, what can I do to get a line in? What I found out, though, is the patients love it. These are patients that are used to being stuck multiple times, and I go in there and I say, listen, I'm probably going to get it in one stick. I'm going to use a little lidocaine to numb the skin so you're not even hardly going to feel it. And they are overjoyed. I actually had a patient's relative call me the Michael Jordan of IV nurses recently. That will be the LeBron James of IV nurses to young people, if there's any young people listening to this. It increases efficiency. I already told you we saved a lot of time. And time is money in healthcare. So you save time, you save money. Also, we don't do convenient central lines in our department anymore. It just doesn't happen because we get ultrasound IVs. Now, this is peripheral IVs. Starting peripheral IVs is all about nursing practice. It's in the scope of practice for nurses. And in our case, we're really starting IVs on veins that are somewhere around 1/4 to 1/2 an inch under the skin. So it's not like a central line. We're only using about a 2-inch IV catheter. So the risks are tiny. But if you really do need a central line, that's where the doctor comes in. Let's start a central line when we need a central line, and we'll get the doctor to do that. The American Institute of Ultrasound in Medicine, the AIUM, and the Association for Vascular Access are all on board with this. They think ultrasound used by nurses has shown a particular benefit as an adjunct. And of course, I don't use the ultrasound on every IV I stick, but I could, but I don't. We do about 10 a day in our department. So what did we decide to make our nurses eligible? 2 years of experience as a nurse and 1 year ED. So if somebody comes in, they're experienced to our ED, in a year, we'll put them in an ultrasound class if they're interested. Be proficient as an IV nurse. Complete a class. Our class is 4 hours long. In the class, we do 5 different phantom arm sticks on 5 different veins. And they have to pass a written test. And they have to get proctored. And they have to do 5 proctored sticks. And then they're independent if they want to be. And to be a proctor, you have to have 20 successful sticks and a refresher. So what is ultrasound? Well, the highest sound pitch we can hear is 20,000 hertz. And that would be like, the lady at the opera that breaks the glass. But the truth is, medical ultrasound is over 100 times higher frequency than that. And the advantage of that is because when you have that super high frequency, it penetrates tissue. This is actually an ultrasound probe. Imagine these little blue dots being crystals. And these crystals vibrate. They're electrically vibrate. They send sound waves into the skin. Some of the sound waves go through and some bounce off. When the ones bounce off, they hit resting crystals and cause them to vibrate. And the resting crystals send an impulse up to the screen, which is a 2-dimensional image that we see. So this is really, really cool technology. And the best part is this makes it so we can get IVs in patients that we wouldn't even know they had veins. That's my favorite part. These are the 2 transducers that we use in our department, the L38 and the L25. We actually just got a new machine that has both probes with one that shares one monitor. They're ultra high frequency, and they're really good for short distances, like an inch. So you get a really good image. Now the 38, if you notice, it's wider. So if you're holding that over an arm, you're going to see more veins. But the 25 is shorter, and the 25, the veins are going to look bigger. So the L25, I liken it to, it's kind of like threading a needle with a magnifying glass, so the hole looks bigger. The important thing about the beam is just to remember that it's a 1 millimeter thick slice. Imagine a person's arm is a loaf of bread with a whole bunch of slices of bread that are 1 millimeter thick. So if you look at a slice in the forearm, that slice is going to look different than if you look at a slice in the upper arm. But as you slide the probe up and down the arm, every time you move 1 millimeter, you're looking at another slice. That's the best way that I can say to imagine, because it is a 2-dimensional image. This is what it looks like. Keep in mind, this is the skin, this is the transducer, and this is looking down into the arm. Over here, these little white dots, these are half centimeter marks. So for example, right here, this says 3.3. This is 3.3 centimeters from the probe up here. The orientation marker is a little nub on the probe, and if the marker's on the left, the probe's on the left. But I got to tell you, the best way, when you're starting an IV, the best way to orient yourself to that arm is, if you're in the transverse out of plane, is if you move the probe to the right, the image, the veins move to the left. That means you're in the right orientation, and vice versa. If you move the probe to the left, the veins move to the right. Now on the left there, you see out of plane, which is like a perpendicular orientation, and on the right side you see in plane, which is just the whole length of the needle and vein. And so the short axis, this is what it kind of looks like. The short axis, the vein is like looking down a tunnel, and the long axis is just kind of like standing next to a river and watching the river flow, kind of thing. And this is an actual live image of a needle going into a vein in the transverse or short axis. And that white spot in the middle of that vein is the needle. And this is an image of a needle going into a vein in the long axis or longitudinal. Boom, in. So what are we looking at? Subcutaneous tissue, which is a mix of, fluid and fat, is going to be gray. Blood and water, because they're liquid, are going to be black. Vascular walls, because they're kind of dense, are going to be whitish. Fascial sheaths are dense, and they're going to be whitish. The denser something is, the whiter it is. Nerves are like blood vessels with nerve bundles in them, so they're gray, white, honeycombed. And I want to mention this right now. If you ever see what looks like a vein or a blood vessel, and it does not compress, and it does not pulsate, do not try to stick it. It's probably a nerve. Veins are round, black, and compressible. When you press down on the probe, you will obliterate a vein. That's why you don't want to press too hard on the probe. You'll obliterate the vein, and you'll actually stick an artery thinking it's a vein. Arteries are round, black, and pulsatile when compressed, so they actually pulse. Bone surfaces are white with a black shadow underneath. Hopefully you're not sticking any bones, because the bones are pretty far from where we're looking. So what is echogenicity? So we say things are echogenic when they're dense, basically. For example, a needle is echogenic. So let's start with hyperechoic. Hyperechoic means it's denser than the surrounding tissue, and as a result, it shows up whiter. Vascular walls are denser, fascial sheaths, and bony surfaces. Hypoechoic means it's actually less dense than the surrounding tissue, and that would be muscles, fat, nerves, and a fresh thrombus. Anechoic means it doesn't echo at all. The actual sound waves just pass straight through, and that's going to be black. That's going to be blood, urine, bile, and shadows from bony surfaces. Interestingly enough, when somebody has a lot of peripheral edema, have anasarca, you actually see black under the skin with little wads of subcutaneous tissue. It's really interesting to look at. It's a great way to determine fat from fluid. And then isoechoic, there's no difference between the surrounding tissue. Fatty tumors are isoechoic. They're hard to recognize. So let's look at a blood vessel. This is the upper arm, okay? This is subcutaneous tissue. This is the basilic vein. This is the brachial artery and veins. We call this Mickey Mouse. Right here, Mickey Mouse is kind of standing on his head. This is probably the brachial nerve bundles in them. So they're gray, white. And then this is just subcutaneous tissue. And these are the veins of the arm, and I don't really have to spend a lot of time on them, just let you know that the basilic vein is the biggest upper arm vein and the most accessible upper arm vein. And some people refer to the antecubital vein as the median cubital vein. and I use a lot of forearm veins when I use my ultrasound. So upper arm veins, bigger diameter, may be deeper. If you've got an obese person, even the basilic vein in an obese person could be 2 centimeters deep. Basilic vein though, and some people you can palpate the basilic vein. It's the most superficial of the upper arm veins, that's consistently anyway. It courses along the medial side of the arm, and it drains into the brachial vein. This is why sometimes I will put my tourniquet on really high in the arm just in case I need to go there. Again, the best part about the basilic vein, it's a long way from the brachial artery and the brachial nerve, and that's because you don't want to go in any arteries and nerves. The cephalic vein is on the lateral side of the arm, and in adults, it kind of disappears. As people get older, it gets smaller and smaller, but always look for it because some people have a significant cephalic vein and they don't have anything else. So always look for it on the lateral side. It's likely to be pretty superficial. Look how superficial this is. This is right under the skin. This vein, the bottom of the vein, is 1/2 centimeter from the skin. You're probably going to be able to palpate this, but that being said, I still wouldn't mind starting it with an ultrasound because it's more fun to start IVs with ultrasound. I'm just being honest. The brachial vein is a whole other story. It's deeper, it's paired with veins, and it's paired with nerves. So it's rare that I would ever consider the brachial vein in the upper arm. Now I will stick the superficial brachial vein in the lower arm. I've done it many times. But if you are going to stick the brachial vein, you want to go for the superficial brachial vein, and you don't want to go, if it's sitting over top of the artery, avoid it. You want it to be lateral to the artery. Sometimes you'll have an actual brachial artery and a brachial vein under it. You're done, and you just can't go there. You can't go through an artery to stick a vein. These are my bread and butter right here, our forearm veins. I use these 1.88 inch catheters, so I want to start my forearm IV so that the tip of the needle is just short of the AC joint. That does two things. It allows them to bend their arm, but it provides the same kind of IV as if you put the IV in the AC because the tip is actually there. You don't want it to go beyond the AC joint because when they bend their arm, they're going to pull the IV out. Same thing with the median cubital. Median cubital, what we refer to as the AC. Now, in several cases, I've put just a regular size IV in the median cubital. One of the problems with ultrasound is most of the patients that we get that are bad sticks don't have good median cubitals. That's why they're bad sticks. And so they just don't have a median cubital. But if you're going to use it, again, you want to put the IV in so the hub is at the AC, not below the AC, because you don't want them to bend their arm and pull the IV out. Nerves, you want to avoid nerves. This is a really good image of a nerve. See how a nerve kind of looks like a vein? Here's a vein, here's a nerve, but the nerve has that honeycomb appearance in it. Okay, so in our department, what do we use to supply-wise? We use regular IV equipment, regular whatever kind of pigtail that you use for your saline locks. And we also you can either use a commercial ultrasound probe cover. We use those 3 by 4 inch tegaderms. And we also have at least one sterile 4 by 4, and I'll explain why in a minute. And sterile gloves or non-sterile gloves, it doesn't really matter. I always like to put benzoin around my needle hub once I've got my needle in before I put my final tegaderm on. And we use the 1.88 inch catheters, but they make them up to 2.2 inches, I believe. And the longer the better because you're getting into these deeper veins. I believe at least one company or two actually has a peripheral IV catheter around 2 inches that's got a built-in wire, guide wires, which that's pretty cool. Explain the procedure to the patient, apply the tourniquet, apply acoustic gel, and locate the vessels. So for a first-time person, I want you to check both arms. So you're going to tell the patient, I tell my patients, I know you've had a lot of problems with IVs, but I'm actually going to do it almost like Superman. I'm going to be able to see the veins under your skin. Not only am I going to be able to see the veins under your skin, I'll even show them to you on this monitor screen. And that's usually pretty convincing because sometimes, people don't like technology. So you put the tourniquet on. I like to put it on high just in case I want to go up high. And then you're going to put, at this point, for starters, you're just going to put regular non-sterile acoustic gel on. You just want to find a vein, okay? So now, get used to holding the transducer in your non-dominant hand, because when you start the IV, you're going to be holding the IV catheter in your dominant hand. So keep a light touch or you will obliterate the veins, and you don't want to do that. Keep your hand stable, relax, and find your vein. Once you find your vein, note the location, wipe off the gel, and prep that area at least a 4-inch diameter. I scrub for a minute and I wait for a minute for it to dry. While I'm waiting for it to dry, I draw up my lidocaine. Then I put a layer of gel on the probe head, like putting toothpaste on a toothbrush. Then I put the tegaderm over the probe head, trapping the gel on the probe head by pulling the sticky part of the tegaderm around the sides of the probe. Now I've got a layer of gel on top of the probe head between the tegaderm and the probe. Then I'm going to put sterile gel on the arm where I'm going to stick the needle. I hold the transducer in my non-dominant hand. I find the vein. I put the lidocaine in. I simply use a insulin syringe. It's perfect because our policy is no more than 0.5 cc's of 1% buffered lidocaine. It already has a 29 gauge half-inch needle. You can see the needle with the ultrasound probe on the monitor. Once I see the needle and see where it is in proximity to the vein, I pull it back a little bit. I squirt a little bit of lidocaine under the skin. That creates a little cloud. And then I make a wheel, just like a TB test wheel, in the skin with the lidocaine. Now that hurts a little bit, but that actually really deadens all the real good nerve endings are in the skin. And it gives me a target for my IV needle. So now at this point, I'm going to stick my needle in. Now, the minute the needle breaks the skin, you're done looking at the arm. You go to the monitor, because now everything you see is going to be on the monitor. Depending on how deep the vein is, I'll start about 1/8 of an inch to 1/4 of an inch distal to the probe, and then I'll angle the probe. I'll tilt the probe so that the vein comes in view. So I use both techniques. This is called the sliding technique, where I actually slide the probe, slide the needle, slide the probe, slide the needle. But I also use the angle technique too, and I'll tell you why. When you use the combination of techniques, you tend to learn how to light that needle tip up. It's all about lighting up the needle tip. Now you need to know the Pythagorean theorem, because the distance from where you stick the needle in the skin to where the needle goes in the vein is a greater distance than from the needle to the probe or from the probe to the vein. Okay, you have to allow for that. And you have to allow for the angle. For example, at a 45-degree angle, which is the greatest angle you should ever put it in at, it's still longer, so you need to allow for how much catheter you want to stay in the vein. If you're using a 1.88-inch catheter, the minimum amount of IV catheter that you should get in the vein should be at least 1 inch, if not 1.25 inches. It's imperative because the further the vein is from the skin, the more movement of the body of the skin will pull on that catheter. Here's an image. This right there's the catheter in the vein in the transverse, and here's the catheter in the vein in longitudinal. Now the problem with longitudinal for peripheral IVs is a lot of these veins we're sticking are really not very big, and to hold that probe over that vein is not easy to do. Now if you're doing a internal jugular or a subclavian, those veins are big. It's a lot easier. So you want to watch the video monitor instead of the arm to find the needle tip. You want to look for blood flash. Continue advancing the needle. Stay on top of the needle tip. You don't have to slide the catheter off the stylet right away if you don't want to, as long as you know where the needle tip is. I have veins that are kind of crooked, and I'll guide the needle tip with the stylet in it. I'll make a right turn, a left turn, because you can do that because it lights up really well with the stylet. You take the stylet out and it doesn't light up as good. And be careful not to stick the needle through the vein. Usually what I do is once I'm in, I'll turn the probe longitudinally just to see where the tip is. And don't go through fascia. If you stick the needle through fascia, every time the patient moves their arms, it's going to pull out that catheter. You want to go through subcutaneous tissue. Like I said, don't insert the needle greater than 45 degrees for a couple of reasons. For one, you're going to go through the vein. You're more likely to go through the vein. Another reason, it's hard to advance the catheter once you're in at that angle. A normal IV goes in at around 22 degrees. I like to put my ultrasounds in at about 30 to 35 degrees. I tend to have my best success. Also, look on the right there. See how as you move the probe up the arm, the needle shows up in the plane that it's in. See, because remember, you're looking at those little slices of bread. And be careful, look at this on the left. The needle is through the vein because you've got the probe in the wrong place. The probe should be much further up the arm. Also, when you do your mapping of your veins, you're going to see that veins go up and then they dive. One of the best places to start an IV in someone that's got a deep vein is where it's the closest to the skin. But in that case, you have to make sure you have the right angle. If you don't, it's almost impossible to change the angle of the needle significantly when you're going in. So you don't want to chase the vein. And that's what happens if you go in at the wrong angle. You want to go in a little bit early to get it in the vein, and then it'll actually follow the vein really well. Trust me, I've learned this the hard way. Another thing, map the vein and make sure, just because you can see a vein doesn't mean you can put a needle in it. You're not going to be able to advance this catheter because of the shape of the vein and the direction. This one, you should have gone over here. This is where you should have gone in, way over here on the left, and cannulated it there. Walk the needle down. I call this the carrot and the stick approach. And this is just, once you get used to doing this, it becomes one motion. When you're learning, it's, move, 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 move. And always stay on top of the needle tip. As you get better and better, it becomes one motion. It is just amazing. I took a vacation in June. I took a month off, had a great time, went to Montreal, New York City, and came back and started these things without any problem at all. Now, this is a video of a patient that I actually did. This is the vein we're going to go for, this little tiny vein. It's about 2.5 millimeters, really small. But you're going to see the lidocaine cloud just to the left of the vein. You're going to see a lidocaine cloud. That's for me injecting the lidocaine right now. See that? That's the lidocaine cloud. And now I'm going to slide the probe, and you're going to see I'm going to put the needle. There's that white dot is the needle. It's going in the vein, and now the needle is in the vein. So I think this is probably a 20 gauge angiocath. So I've got a 20 gauge angiocath going in about a 2 to 3 millimeter vein, no problem. Now the truth is, this vein is only 0.5 centimeter under the skin, and less than 0.5 centimeter, and it's straight, and that's key. If it wasn't straight, I wouldn't be able to do it. Now on this slide, up here, you've got the brachial plexus, and I don't want to go in a vein, even though there's a bigger vein at the brachial plexus, I don't want to go there because there's an artery and a nerve. So I've chosen this vein over here, this vein, as opposed to this vein. Because this one's right next, there's the brachial artery. So see how much safer this is to be in this vein. So that's exactly why I did that. And again, when you see the needle, you don't see the needle. That's because when you don't see the needle, I'm moving the probe up the arm. Now this is in a phantom arm, and you must, if you do this, you must get a phantom arm with several different sized veins. In this one, I'm going to be putting a needle in. There are 2 veins bifurcate into this vein, and then I'm going to turn the probe longitudinally so you can see, sort of to check my work, you might say. So there's the needle going in the vein. And this is a huge vein, by the way. There's the bifurcating veins. As I'm moving the probe up the arm, these veins are bifurcating in. And here I turn the probe sideways to get a longitudinal view because I'm going to light up my tip. And then I light up my tip, and there's my tip in the vein right there. Tip is in the vein. Mission accomplished. This is a real patient that as a lady a couple years ago had an acute stroke. We needed bloods. We needed creatinine and BUN because she was going to get a CT scan with contrast. And if she had a stroke, we needed a good vein to give her TPA. She had no obvious peripheral veins. I swear to you, she had nothing. She had no AC. She had nothing. And I found this in her forearm, which actually the tip of the catheter, again, was at the AC. This vein is a 1/2 centimeter in diameter, straight as an arrow, and it's about a 1/2 centimeter under the skin. So you're not going to see, there's no way you're going to see this with one of those AccuVein devices. You're not going to palpate it. So this is me starting this, and it took me like 10, 20 seconds to do the whole thing. That was my lidocaine shadow there. Okay, here comes the needle. I just broke the skin with the needle. Now the needle is going in the vein. Now the needle is in the vein, and I'm advancing the stylet. I haven't even taken the catheter off the stylet. I'm just doing the whole shebang. And it's in. That's it. Piece of cake. Now, once you're done, you're going to want to attach your saline lock, get your blood samples, flush, secure your dressing. What I do, there is going to be some gel. So I take, first of all, I take a sterile 4x4. Remember, these veins are a little bit deeper, so sometimes you can't put your finger on the catheter tip and keep blood from coming out. So I put a sterile 4x4 under the hub, just in case any extra blood comes out before I secure my saline lock. And then I wipe off any excess gel. And then what I like to do is take a benzoin swab and make a little horseshoe around the hub. And then I put my Tegaderm on, and that really tends to make it stay in real secure. And then I tape the hub below the Tegaderm just to keep it from sliding out. And then we're going to initial date and time. And then we're going to take the transducer cover off, get the gel off the transducer cover, and clean it with an appropriate cleaning solution. Don't leave a dirty transducer cover for the next nurse. That's just like bad form. Trust me. And again, insert the needle less than 45 degrees. You have to worry about infection. There's a risk. You can perforate a vessel. You can have extravasation. You can accidentally have it come out. I had one come out on a kid. Unfortunately, I was able to get one right back in. And that's, again, it's because I didn't have a splint on the kid's arm, and mom was holding his arm, and he got loose, and it came out. So what I do with kids is I actually put a splint on their arm before I even put the IV in. That way, it's a lot safer. All of these things, by the way, can happen with a regular IV. That's the deal. You can do every one of these putting in a regular peripheral IV. Trust me, there's no question about it. So that's why this is in our scope of practice. Another thing to keep in mind, you must hold the probe gently, because what will happen is you'll see what looks like a vein, and you'll be pressing so hard that you're obliterating the vein, and you'll stick the IV catheter in an artery because you're pressing so hard on the probe. So you press on the probe just to identify the veins from the arteries, okay? The veins will wink. The vein will actually disappear, and then you lift up and it appears. The artery will pulsate. This is an actual thrombus at a valve site. In the longitudinal view, you can see valves if a valve is closed. And you don't want to stick a needle in a valve in a vein with a thrombus. Again, more tips. Don't go for veins deeper than 1.5 centimeters. The success rate is less than 10%. Make sure the vein is big enough for the catheter. Map the vein to see where it goes. Never stick non-compressible vessels. Never, ever. Always take the probe beyond the needle tip, bring it back until the tip lights up on the screen. This is the only way to know where the tip is in the transverse view. Be careful with the brachial veins. They always have an artery and nerve nearby. I mean, I stick them a lot, but you have to know what you're doing. Never insert the needle in an angle greater than 45 degrees. That's like the 4th time I've said that. For proper orientation, the images on the screen should move to the left when you move the probe to your right and vice versa. If you're looking up the arm, that's what you want. Too much pressure with the transducer will cause the veins to collapse. And at the end of every class, when I give a class, this is our mantra. This is how you do it. You center the vein, you advance the probe, you advance the needle. You center the vein, you advance the probe, you advance the needle. You center the vein, you advance the probe, you advance the needle. You get it? And then that's where it ends. It ends up right in the middle of the vein. And those are like the 3 key things. If you can do that, you can be excellent at starting ultrasound-guided peripheral IVs. So in summary, the ultrasound machine easily identifies blood vessels, it identifies fascia, it identifies edema, it identifies nerves, bones. It provides real-time visualization. You learn to control where the tip is of the needle at all times. And you learn how to really get that needle to light up. When you're starting out, it's a little bit more difficult to get the needle to light up, but then it becomes just automatic. It improves the safety, accuracy, and decreases complication rates. Our doctors do not put in convenience central lines. Our doctors do not put in convenience EJs. And we don't put in convenience interosseous either. We get our IVs because we use the ultrasound. And it shortens the time for starting an IV. We did a poster about 5 years ago where we had a small sample. It was like 39 or 40 patients, but we saved about 30 minutes per patient by using ultrasound. So this is a real game changer. And in our department, we've started over 5,000 ultrasounds. I've started over 500 myself. We have 30 nurses that can do ultrasound IV, and we just trained 10 of our IV team nurses, and we just created we have 4 trainers now that can actually give the class. So this is a real exciting thing, but it's just made my life so much better because I can't stand not being able to start a line. And that's, for me now, that's history. So it's time for questions.